PCO2 around 40. So the
PCO2
PCO2 is
here is low. So what does that tell you?
um, was
Very good. And we were told that the child is breathing 44. So it fits in. It fits in with a washout of CO2. Very good. Then
PCO3.
PO2 is normal for a VBG 50 and bicarb is low. So it's the dehydrated state. Bicarb is low. Shows the dehydrated state and calculate the compensation.
Bicarb is due to a compensation of what?
Primary metabolic acidosis.
It can be, no. So now tell me the reason for primary metabolic acidosis in this whole scenario. We've been, see, you have to interpret ABG, VBG in context of the clinical story. So is this a candidate for metabolic acidosis? Why?
Low intravascular volume.
Hypoperfusion of the tissues. Correct. Okay. What about the renal function? Creat looks normal, no? 0.8. So thankfully, there's no kidney disease, serious kidney disease, right?
Calculate the EGFR according to the
So
height.
what is the EGFR? He told us the height, no, 96. Shall make it 100. Make the 96 100 for ease. So what is the formula? Who knows the formula?
0.413 into height upon creat.
0.413 also make it 5, 0.5. Simple curve. So 100 and make it 0.5. 60, but I am saying even 50 if you take upon creat. How much is the EGFR? EGFR is coming to 60. So normal. Normal for this child. It's not normal. It is low.
Low.
So this creat is high for this child. 0.8 is not normal for this child. So remember that look at the creat with the help of this formula. Right? Go ahead.
Before this 75. So that's 0.75. So this is a mildly raised.
Albumin of 3.5, nephrotic. Life.
So this is just X-ray on presentation. It's a chest X-ray of PA view taken in erect position. We can see that the heart borders are, the heart shadow is enlarged. The cardiothoracic ratio is more than 0.5. There's also heterogeneous opacities on the right side and a blunting of the costophrenic and the cardiophrenic angles.
Standing X-ray. He is not being court-martialed. Everyone answer. Are you sure it's a standing X-ray?
Stomach gas will be above.
So you can't see the gastric air bubble here. So if the gastric air bubble is not seen, you can't say it's a standing X-ray. This could well be lying down.
Second, I want something from you all about the chest part. He said heart is enlarged and all that he said. But I want the first thing which impacts the heart shadow. And what is that? Diaphragm is what? Low, high, high. The film is in inspiration or expiration? Expiration. You can hardly see one, two, three, four or five spaces, right? So exactly, heart may look big because of that. We are not saying heart is not enlarged, but these are all the confounders. So in exam, you have to come out with all this. Say heart looks big, but probably lying down, probably expiratory. So I will have to recheck with another film.
The child has not passed stool since 8 days. The likely fecally loaded
And
liver might be enlarged.
yes,
Comment on gas shadows in abdomen.
Looks like the colonic gas.
Of gas shadows in the abdomen. You expect too many gas shadows unless there's something which is obstructing. Maybe there is some fluid over that.
The upper part of the abdomen is almost devoid of gas. So there is something coming in the way there. So again, your findings of significant hepatomegaly seems to be there, right?
So the child was shifted to PICU. He was evaluated again. He had a heart rate. So on adrenaline, he had a heart rate of 120, a respiratory rate of around 36. His BP had risen to between 50th and 90th centile. His peripheral pulses and central pulses were poorly felt. His extremities had further become cold towards elbow and knee. uh, we start because of his BP was 160, around 160, 100 over 60. So thinking of a wide pulse pressure, we tapered the adrenaline, added noradrenaline instead. We did a point of care ultrasound. The point of care ultrasound echo is the video on the screen. So the echo shows the heart surrounded by a lot of echogenic fluid with septations present in the fluid, suggestive of a pericardial effusion. Uh, could be a pyopericardium. So the lung focus showed pleural effusion as well as B lines in the lung, which is suggestive of pulmonary edema. We also did an abdominal focus, which showed about mild to moderate ascites, uh, perihepatic and perisplenic fluid collections. Based on this, we sent a cardio reference. The cardiologist came and did a proper 2D echo. They said that the heart function was normal, but of course, there was gross pericardial effusion. The child was stable on adrenaline, noradrenaline. So we waited until this happened in the night. So we waited until next morning to do a therapeutic tap because the child was in impending cardiac tamponade. So we waited to do a therapeutic pericardiocentesis, which yielded the fluid on the left, the reddish serohemorrhagic fluid. There was about 150 ml that was drained from the heart. We also did a pleural tap, which yielded that golden colored fluid on the right, around 40 to 50 ml. Diagnostic tap was done. So the pericardial fluid, 150 ml was drained. It was red in color with a total leukocyte count of 2,196, a differential count of 80% lymphocytes with occasional macrophages. The pleural fluid, on the other hand, had was 50 ml was drained, yellowish in color, total count of 432, and a differential count of 75% lymphocytes. the protein and the LDH levels in the pleural fluid is suggestive of exudative pleural effusion. The LDH, serum LDH, corresponding serum LDH was 911. It's suggestive of an exudative pleural effusion. The ADA is within normal limits, but we have suspected malignancy and COX. So for malignancy, we have sent cytology for both fluids, and for the COX, we have sent a gene export ultra to Hinduja. Reports are awaited for both.
You confirmed a lot of abdominal fluid with the USG.
So mild to moderate ascites, tappable.
So even now you should go back and look at the veins. Sir was asking, veins in the neck are very important. In this child, mostly you would have very prominent veins in the neck, which would tell you that there is a obstruction at the pericardial level. And that's why the
So on the focus on the point of care ultrasound, we also looked at the IVC. The IVC was properly distended. So we did suspect obstructive shock in this child once we got the entire picture with the effusion.
yeah.
I think every hepatomegaly you must look at the neck vein, because the neck veins in this child are not only with hepatojugular reflux present, but it could be absent. So there would be an engorged neck vein, but absent hepatojugular reflux would say that it's obstructed. Often the pericardial problems come up with a large liver, and if you miss the neck veins, then you have missed the thing. So I think overall, what is interesting is there is the hemorrhagic fluid there. Now, obviously, it is more exudative than just transudative. If it's exudative, then there has to be some inflammatory disorder there. And therefore, I go back to our earlier discussion that there is some vasculitic illness causing nephrotic syndrome like picture and hemorrhagic fluid there. Again, if you see the typical nephrotic syndrome or even atypical or complicated, the pericardial effusion of significance is not a common feature. And therefore, here, what is prominent is the pericardial fluid, and not only that, hemorrhagic fluid. Hemorrhagic fluid would mean an inflammatory thing.
Now, apparently, there's no renal disease because albumin is normal.
Yeah.
So this is only a cardiac illness. So in fact, after you finished, I was going to say this. So see, puffiness of not eyes, puffiness of face is a symptom of SVC obstruction. But then that's where the trick of history taking comes in. That whether it is puffiness of eyes or puffiness of face. And the second thing is, earlier when we mentioned that the sequence is very important. So you gave us a sequence of edema, that puffiness of eyes, then pedal edema, abdominal distension, and then you said breathlessness over 6 days. But if you give a story of what happened on day one, so day one, some puffiness of face, nothing else. Day two, little breathless but pedal edema or something like that. Then it would make you differentiate a heart disease from a nephrotic then and there on that day only. So these are the fineries in the history. So going back, SVC obstruction does give you a face swelling, but your neck vein would be very prominent.
Agreed that only pericardial effusion should not cause edema. Now, this child obviously had edema feet also. So, to that extent, the story given, yes, you made a point that a prominent facial edema versus the periorbital edema would make a difference. But there would not be a generalized anasarca in a pericardial disorder. So, that needs to be explained. So, again, going back, if you do not have a low albumin there, you have given us protein. What was the albumin like?
3.6 or something.
3.6. So that is too good for any hypoalbuminemic condition. So the condition, again, the problem is that why do you have a generalized edema? You might check the findings again, clinical as well as this. Okay, but pericardial effusion by itself should not cause generalized edema at all.
So, sir, I was in fact thinking that since you have a exudate at both the places, whether it's a exudate there as well, whether it's like a polyserositis, and whether malignancy comes up ahead of other things. I was just thinking of that.
Malignancy with polyserositis is unusual. Pericardial alone may be a cardiac malignancy or whatever. So I feel this is certainly an immunological inflammatory disorder, and it's not only vasculitis because there are multiple areas involved. So again, we will have to look at carefully whether the test results need to be rechecked again. Generalized edema is a feature of a renal problem. Okay, it's not a cardiac nor anything else. I think Penny has been checked, is irreversible, yes, all that. But albumin being so good, that bothers us. The question is, could albumin be near normal in an acute glomerulonephritis? And then this is the nephritis to my mind, not a nephrotic syndrome per se. And all that would be. I will still bet on a nephrotic renal disorder. Okay, because generalized edema,
What about a urine test?
Spot urine albumin was 1 plus.
24 hours urine albumin is normal,
24 hours has not been done.
or urine creatinine ratio is normal.
Urine protein creatinine ratio was done outside. It was not suggestive of nephrotic infiltration.
How is the child now?
So after the tap, the child is clinically better. We're tapering his BP is better. We're tapering the noradrenaline. He's eating well. He's passing urine also. So
I think, as I know you well, you owe to tell us what is the final diagnosis. We have never been hearing that at all. Okay, because every time somebody here promises, they are not there thereafter. So we missed to know correctly where we made a faulty analysis or whether that. But I think you may have to recheck many things again. Okay.
Sir, breathlessness coming up later is so much of edema. If not, you have suggested nephrotic. There's so much of edema and breathlessness. The cardiac problem should be this much of edema and this much of. So here, because any cardiac failure must give rise to it. Even the heart rate was some 82 or don't know, but
Good case, and tell us next time. Yeah. So, thank you. There's a second
you.
case.
Took 1.5 hours to know that we are ignorant. Isn't it? That's funny.
everything we starts with puffiness of face and then later on followed by pedal edema. We always thought of nephrotic, but sometimes we have to believe it. Breathless. He must have been tachypnea. Without tachypnea, there can be no cardiac. Tachypnea could have been attributed to ascites, mechanical obstruction. In children, JVP we often overlook because children have very short neck. बच्चे लोगों को मान कहाँ है हमारे देश में? लेकिन so there is it's difficult. We are not an adult will first look at their face. We really don't look at them. And I remember one case Dr. Shah had shown an adult who had such marked neck vein shear. And then he asked the diagnosis, so everybody said CCFA. He said, but the child is not, the adult is not tachypneic only. If he has so much of veins, it is not tachypneic. The pathology is in the pericardium rather than in the heart.
7-month-old male child, third by birth order, born out of non-consanguineous marriage, hailing from Raigad, resident of Kanpur, Hindu by religion, Mohita by community, brought by the parents with the complaints of failure to gain weight, noticed since 5 months of age, crying while micturations in 7 days and fever since 4 days. A complaint of crying while micturations in 7 days during the entire stream of the micturation, associated with passing high-colored urine and decreased urine output, not associated with any pulse, foul smelling or blood in urine. His history of fevers in 7 days, which is high grade, documented spike of 102 degree Fahrenheit, relieved with medications intermittently and active in interfebrile period. Not associated with any rigors, not associated with any rash. There's history of lethargy present and history of recurrent cold and cough present. There's no history of loose stools, no history of passing hard stools or constipation, no history of refusal to feed, no history of bottle feeding, no history of swelling in lower limbs and upper limbs, no history of recurrent diarrhea, no history of cycle, bluish discoloration of body, no history of recurrent skin infection, no history of cox or cox contact, or no history of polyuria. There's no history of any past admissions. ANC is registered, 2 USG scans done, told to be normal, 2 TT injections and full calcium supplements taken, not taken. There's history of blood transfusion, 3 pint in mother at 9 months of gestation. There's history of hypothyroidism, for which she took thyroxine 100 microgram, and vitiligo is also there in mother, for which she took treatment, but the details are not known, what treatment she has taken. There's no history of PV bleeding and no history of the GDM, PIH, or any other complication. Birth history, full term, normal, cried immediately after birth weight of 2.5 kgs, no history of NICU stay. There's history of neonatal jaundice on neonatal jaundice, received phototherapy for 2 days. TFT not done, received birth vaccines, discharged on day of flight 4. Immunized till date, 3.5 months. Developmentally, gross motor, head holding is only there, which was achieved at 2 months of age, the DQ of 28%. Fine motor, bidextrous approach present, DQ of 57%. Language only cooing present, DQ of 28. Recognizes mother and achieved since 3 months of age, DQ of 42%. Global developmental delay is present. Dietary wise, she's on exclusively breastfeed till 6 months. Still breastfeeding only there, and she gives dal water and rice water, which was started since 1 month only. Predominantly, breastfeeding is only there. Family history is not significant. She has 2 elder siblings, which are normal, and she belongs to upper lower socioeconomic class.
Completely.
7-month-old baby, failure to gain weight since 5 months.
That's the chief and only complaint.
No, and fever since last 7 days and crying while micturition since last 7. So failure to gain weight since 5 months means what did the mother exactly tell you? How did they notice that there is failure to gain weight?
5 months of age, baby was doing well. According to her, she was active and playful and was interactive also. But since 5 months of age, since 2 months, she's not interacting well. Then weight, she's not gaining weight after that also. And uh, initially she used to say, मतलब wing के अलावा भी monosyllable भी था, but now it is not there as per the mother. She said that.
And this fever is documented or not documented? So 7 days of 102 fever. Okay. And crying while micturition every time. And associated with high colored urine. Decreased urine output. So decreased urine output means exactly
He only passes 2 to 3 times per day.
in these 7 days, what is the intake like? Food intake or what breastfeeding or whatever.
Food intake, she accepted well only. Like the breastfeeding, she took well.
See, the point is that obviously, again, the history is not in a very good flow. So, last 7 days, first of all, if it's such a small baby, 7-month-old baby now, no? 7-month-old. So, in a 7-month-old UTI is never a lower UTI. So, they don't cry while passing urine. It is a upper UTI and they would just have high fever. That high fever we are saying is 102, just 1 or 2 spikes a day. Normally, it would be very stubborn, difficult to control fever in a UTI in a 7-month-old, right? So that's very unusual. Then further points are that this is not lower UTI at 7 months, but lower UTI is associated with increased frequency of urine. Here you have decreased urine output. So all those things just don't match, first of all. Finally, 2 months of not gaining weight is again not connected to this present illness in any way, right? So present illness is some febrile illness. We are not sure what it is. Not gaining weight, as of now, we don't know much. In fact, those milestones are very important because even when you gave us the milestones, I was wondering what you mean by that because gross motor head holding achieved at 2 months of age. Is it normal or abnormal? Normal. 3 months, no? So 2 months is normal or abnormal? What can be the abnormality? What can make a baby achieve head holding faster? Spasticity. So, I mean, just bringing, not, I don't know whether this baby is spastic, but then you've said DQ 28%. So, are you meaning that in gross motor today, the baby is only holding head and nothing else? So, so this is very important that head holding achieved at 2 months, and after that there is no further gross motor development. Is that the story, or there was gross motor development which has regressed?
Not gain any milestone after that.
Similarly, bidextrous approach is what the baby is doing now, according to you. So that is why you put it as 57%. So what is not there? Transfer of objects is not there. Unidextrous approach is not there. And do they remember when did the baby open the fist or something like that? No. Okay. Language, baby is cooing. Started at what age?
3 to 4. Nothing after that.
What are your thoughts about this developmental history? You want to speak something? Hmm? What are your thoughts about this developmental history?
So basically, there's delay in every aspect of the development, that is
Correct.
gross motor, fine motor, language also.
When did the delay start?
That 2 months, no, that is early.
At around 3 to 4 months, because like the gross motor also head holding, if assuming she has gained by 3 to 4 months. Rest all milestones are also around 4 months. So mostly that up to 4 months she was growing well and developing the milestones, and after that someone's.
Now, suppose you were the person assessing this baby at 3 months. What would you have said about the milestones at 3 months of age? Normal. So perfectly normal till 3 months. Then at 3 months, development button switched off and no further development. Is there any disease which works like that? So these are the things that we have to pick up. So something is wrong somewhere. Either our history needs to be better, or they have not given a proper course or something. But what I'm trying to say is this can just not happen that, okay, bang normal from birth to 3 months and then suddenly switched off and no further development, right?
Example, social recognizes mother achieved at 3 months, and you said that IQ is 42. That means nothing achieved, or you are not assessed after that.
पण तेवढंच आहे. आता पण only recognizing mother. So because it is a 7-month-old baby who is doing what they should do at 2 months, so
What else do you want? She recognized at 7 months, 3 months. At 7 months, what should she do? More than recognition. Stranger recognition will come at 6 months. That's not very easy. All these things are not very easy to recognize. 6 months ko some babies can have no stranger anxiety at 7. So anything between 3 months and 6 months has it achieved. Okay. Because nothing much can be achieved after 3 months to 6 months. As narrated by the mother. We are not very sure whether there has been a developmental arrest after 3 months and achieved very good up to 3 months.
Even in the history, exclusive breastfeeding for 6 months. Then complementary feed started since 1 month. How could it be exclusive breastfeeding? Yeah, but this is okay, just last 1 month. But on exclusive breastfeeding, the baby is not gaining weight. Then what is the problem? So I think the first thing is that uh, exclusive breastfeeding, yes, but is the baby asking for a feed, or baby is happy with it? If the baby on exclusive breastfeeding seems to be happy, stomach full, then that means there is something obviously wrong. Whereas if the breastfeed was not adequate, the baby would be crying. So I think we want to know whether exclusive breastfed baby was apparently happy.
Yes, sir.
Apparently happy. So
You
why
breastfeed well.
why is a happy exclusively breastfed baby not gaining weight? That means breastfeeding is exclusive, but the intake of milk is not enough. And that is not uncommon. Okay. The baby keeps on sucking, baby is happy, but baby is still starving. So I think what probably you wanted to say is that what is the present achievement in each? And it looks like that at 2 months it is too early to hold it, and nothing has happened thereafter. So there is some disparity. But this is just to bring up that the best way to say is what is the present achievement and when did earlier achievement were attained. Then only we know. Of course, 7 months is too early to say whether it's a static or progressive. But the birth history was normal, right? So there was no apparent any perinatal insult. Whether there is something antenatal, postnatal, there is nothing. So the question is it some syndromic abnormality? Is it some genetic disorder? So all those things come into play.
See, theoretically speaking, if the semblance of this history is to be taken as correct and therefore initially normal and then development going down, like you were almost saying regression, like on one or two things the mother seemed to suggest there is regression, and then not gaining weight could be the beginning of a neurodegenerative disorder. But there are still lot of other things that are to be asked and which are missing and which don't fit in, right?
I took it since 1 month, means since 1 month of age. So since last 1 month.
7-month-old female child with complaints of crying while maturation with fever and not able to gain weight. Third by unborn child in a globally developmentally delayed and immunized till date with history of recurrent UTIs, probably a case of UTI with GDD. On examination, dull looking lethargic, a febrile heart rate of 124 per minute regular and RR of 40 per minute regular rhythm. Saturation was 99% on room air, peripheral pulse is well felt, extremities warm, and CRD less than 3 seconds. There was pallor present. AF is at level 1.5 centimeter, 1.5 centimeter. Frontal bossing present, lustreless here is there, dry skin is there. No facial dysformism, no signs of vitamin deficiency, wheezing and increased work of breathing development. No signs of vitamin deficiency, rest normal. Anthropometry, weight is 4.4 kgs, less than minus 3 standard deviation, length of 66 centimeter, 0 to minus 1 standard deviation, MUAC of 10 centimeters, less than minus 3 standard deviation, head circumference of 38.5, less than minus 3 standard deviation. Weight by height is also less than minus 3 standard deviation. SAM with microcephaly there, and according to Dine's formula also, microcephaly is present. On per abdo examination, soft, non-tender, and liver of 2 centimeter below right subcostal margin present. Soft. And the system examination with the normal limits. Two point five. 7-month-old female with complaints of crying while maturation with fever and not able to gain weight. Third born child in a global developmental delayed immunized till date is a probably case of severe acute malnutrition with GDD secondary to very hypothyroidism, as mother had hypothyroidism in ANC and TFT was not done at birth. Labs were suggestive of pancytopenia on presentation, hemoglobin of 5, total counts of 3,000 and platelets of 84,000. And on PS, obviously was hypochromic, normocytic, and macrocytic. And RFT within normal limits, and iron profile is also normal. Urinarium LFT is within normal limits, and urinarium suggestive of pus cells 25 to 30, protein 3 plus occult blood present, RBCs of 8 to 10 cells, and bacteria present. USD also suggestive of irregular bladder wall thickening, suggestive of cystitis.
Done at T3, T4, TSH.
Child.
Saying because the child is sick, they are waiting because just now the report will not be normal.
Is hypothyroid microcephaly? Then why are we talking about hypothyroid? Okay, just because he's lethargic. Okay, so that microcephaly makes you say that it's not just hypothyroid. So lethargy may be due to varieties of reasons. That's not the thing. In fact, macrocytosis with pancytopenia, yes, that's another issue. But so why are we calling it hypothyroid? What is the length like? Yeah, but the weight length ratio, look at that. Normally, hypothyroid will have a normal or a slightly higher weight. Now, you could say this hypothyroid is also deficient in calorie, so make another issue. Good thought. Yeah, but that, no, yeah. So 66 is not, but 4.4 is pretty low. So it doesn't fit in a typical hypothyroid unless there is something beyond hypothyroid. And then why bring in hypothyroid at all? I think microcephaly puts me to say that floppy child, not spastic. But we don't know 2 months whether it really has spasticity. On examination, you haven't said spasticity, right? No. So there was, okay.
History of constipation, posterior fontanelle, slow relaxation of jerks, upper segment over here. I mean, there are some 10, 11 signs which are subtle, which are there at hypothyroidism. Okay, one could take an X-ray of the knees, and if it doesn't show anything, then the child is at this age. The X-ray which knees is a good X-ray to take.
No, but the other important point is that this hypothyroid, if at all we are taking it as congenital, right? It started right from birth. And the first 4 5 months, there is no problem at all. Feeding well, growing well, developing well, first 3 months. So that's very funny for it to have started as hypothyroidism, right? And I mean, you can't have acquired hypothyroidism at this age. These are the thoughts. Then, of course, the microcephaly.
Is there a goiter? Is there absence of thyroid?
Like, what we were unable to place is why should a child who's been exclusively breastfed be firstly be Sam? Because as per mother's history, she has fed well. She's saying that she used to give as per requirement. Child was happy. Child used to sleep well. She's also saying that she has gained weight till 5 months of age. And why has she now lost all the weight, or why is she now severe acute malnutrition? And also, like, we chose this case because we wanted the child to come. The child was probably, the child is very lethargic, very apathetic. The skin is very dry, coarse skin, and like the eyes also, they're very sunken. So that child had some sort of lethargy and that look to herself. So that made us think maybe hypothyroid. And given the mother's history of having hypothyroidism, and she said it was uncontrolled also during the ENPP. The pancytopenia, we like B12 deficiency. The mother was also B12 deficient, so we attributed to that she was being breastfed.
For 7 months, 60 centimeters was a good length, I thought. Yeah.
10th is good, but like why?
And
the
when
weight?
is a hypothyroid baby born to a hypothyroid mother? Except one thing, endemic hypothyroidism due to iron deficiency. Both the babies and the mother could be hypothyroid. Otherwise, hypothyroid baby almost is never a product at birth. The baby may develop autoimmune hypothyroidism later on.
How are you treating currently? You're treating as UTI. Let us know next time about this case also. What it turns out to.
That ultrasound showing cystitis and all doesn't mean anything at all. Okay. Especially in an infant. Infant has a frequent passage of urine. The bladder looks small, and therefore they say hypertrophy. And then they would say it's cystitis. So that's certainly not of any significance at all. Anyway, I think next time we need to know both Okay, this is simple to confirm or otherwise. Okay, yours is little difficult to understand what final thing, but we'll be happy to know it. Right? Even suppose you are busy next Wednesday, leave a message with somebody who is going to be here, or you could even send us an email. Let us know what it is.
From the online audience, anybody wants to say anything?
I'd like to say something, and first of all, Happy New Year to everyone and to Sir as well. What a lovely case the first one was, and so was the second. I just wanted to ask whether a paraneoplastic syndrome, like secondary to neuroblastoma, something could present that way.
Neuroblastoma.
Neuroblastoma in infancy is a very fastly growing malignant tumor, comes with
Yes, sir.
fever of unknown origin and often missed and picked up with secondaries in the bone somewhere. So per se, that should not be a consideration to my mind.
Okay, sir. Or any other paraneoplastic syndrome. In the first case, with so much of hemorrhagic pericardial fluid and pleural effusion.
I think again we said that generalized edema is not a feature of pericardial and pleural or polycirrhosis. So there is something more than that.
Yes, sir.
I think as Dr. Khare said, generalized edema of a short duration, acute onset is nothing other than renal for all practical purposes. I'm aware
Okay.
that albumin is normal here, but that's why I
Yes.
thought we must recheck the history, recheck the test results, and then kind of come to a conclusion, because when nothing is fitting, of course, it could be our ignorance, but we need to check whether there is any other fault in understanding our history or the laboratory results.
Yes. And whether the second patient could be something like osteopetrosis with microcephaly or pancytopenia.
So, I mean, osteopetrosis, right now, there's not enough organomegaly to go by.
Yes.
And delay also is not explained. Developmental delay is also not
Delay.
explained.
Or some other
There are
congenital myeloid dysplasia.
Yeah. So only thing is that, see, the things are unconnected, meaning as in the hematological abnormalities seem to be, I don't know, you can't correlate the developmental with that whether B12 can explain everything, but B12 can't explain microcephaly. So there are
Yes.
many things which don't fit into each other.
Yes. And that's what makes it so interesting.
Chal.
Thank you, Dr.
Thank,
Amdekar, for analyzing it so well. Thank you, Rajesh, and all the faculty who have made it there and the children who have presented.
thank you, Anjali. Anyone else
Thank you.
has any other point to make or anything to ask?
Dr. Sushma Kore has mentioned lots of things.
Yeah, we sir has almost picked up most of them and commented on that as they
Yes.
came along those comments.
Yes. Thank you
Okay,
so
fine.
much.
Thank you. Thank you. So we will meet next Thursday. We'll keep you
Yes.
informed on the Thursday class group. Yeah.
Yes.
Okay.
Thank you
Thank
so
you.
much.
Thank you.
Delightful.
Thank
Very
you. Bye.
delightful session.
Bye. Bye.